Bien, hola a todos.
Hello to everybody. Are we live? Welcome wherever you are, whatever time it is where you are. Welcome to the new session of this CEPA Aula, together with DENTAID. Thank you very much to all of you who are attending these webinars, because you're the reason for organizing these webinars. Of course, I would like to thank the speakers also. They are very, very high-level speakers, as you have seen during the next 4 sessions. Of course, I would like to thank CEPA, because they are always organizing very interesting initiatives. Also the Ibero-American Society of Periodontics Federation, and also thank you to DENTAID, not also for their commitment to prevention in oral health, in this case also speaking about general health, but also because of their commitment with the education in all the fields of the oral and dental field, like what we are speaking about today. We're going to start with the first of the 4 webinars we have planned about how to transform the dental office into an area where we promote general health. It's a kind of new approach, and I think it's something that's really important for all us, all the professionals of the oral healthcare, our staff, everybody. And for this, we're going to start to hear Dr. Blas Noguerol, who's going to speak about the mouth and the whole concept of the promotion of health. Dr. Blas Noguerol, apart from being a very good friend of mine, is doctor in medicine, master in periodontics by the Complutense University of Madrid. From the first promotion of the periodontics master of that university, he has been past president of the Spanish Society of Periodontics, and he has been a pioneer in what is known as Alliance for Health, for oral and general health by CEPA, which is what we're speaking about today here. Especially in the cardiovascular field, he has worked a lot. He was very involved in what we are doing right now, which is now perfectly consolidated. Thank you very much, Blas, and the floor is yours. Yes, I'm going to share my screen. I think everything is ready to go. Yes, perfect. Well, thank you very much to CEPA. Thank you to DENTAID. And for me to be able to participate in this trio with Dr. Miguel Carasol and Mariano Sanz is something very special for me, because Miguel, as he said, was my colleague in my postgraduate studies, and Dr. Sanz was our teacher. Now we are friends. We have still maintaining our contact, and we haven't seen each other for a long time because of this pandemic problem we have. So it's a real pleasure to see you, even if it's through a screen. I'm going to start with my presentation. And what I would like to start with an image which can be kind of shocking at first sight, which looks maybe like very sensationalist. To start presentation speaking about the Spanish flu related to COVID. The Spanish flu, wrongly called Spanish flu, because it started in the United States just when first World War was finished. Many of the problems we have as a society, and how we are able to prevent it, relating also oral health with general health. This epidemic was a worldwide tragedy. We have to consider, and this is very important to take this into account, the famous Spanish flu of 1918 affected half the population. It's important to remember this, because we are saying that this was a brutal pandemic with a magnitude which was much higher than what we are experiencing right now with COVID. And the percentage of mortality was around 70 times higher in the Spanish flu of 1918 compared to COVID-19, which we're experiencing right now. In other words, we should relativize, we should put this tragedy terms into a more relative terms. It doesn't mean that it's not important what's going on right now. But this also teaches us a lot about what prevention is able to do or not. This flu of 1918 appeared when we didn't have too much knowledge. We hardly knew about viruses. We started to know some things. Of course, we didn't have any vaccine. And we have to acknowledge that at first, even it was thought that it was a typhoid disease until they saw that it affected also younger people. And it was really, it has a huge impact on the healthcare institutions worldwide. Our present pandemic is happening in a totally different context. We know much more about viruses. We've been able to generate highly efficient treatment systems, despite the high mortality we had. The treatment modalities have been efficient. And we have been able to develop a vaccine in a very short time. And we know much more about viruses. But the reality is that up to January of this year, we have been in a situation which was quite similar to that of the Spanish flu in 1918, 1919. Social distancing, masks, washing your hands, ventilation. The recommendations were the same as in those days where they didn't know anything about viruses. The same recommendations as we are receiving right now after a whole century, after 100 years. This is our reality. It's also true that initially we were caught off guard, so to say. We didn't have the resources. We didn't have a hospital system which was prepared for such a high number of patients, because our hospitals were based on minimum stays in the hospital. And we had to improvise everything. And this was a huge problem. This was the situation we had to face due to COVID-19. And prevention has not been especially efficacious in that sense. But let me go back 40 years in time. I would like to mention these authors, Level and Clark from the University of Harvard. 40 years later, so 60 years ago, 40 years later, after the Spanish flu, they established a knowledge of the different diseases depending on the periods of their pathogenesis. They defined it as that we had a pre-pathogenic period, a pathogenic period with an asymptomatic and a symptomatic phase, and a post-pathogenic period, which was the phase where the disease had passed and we were facing a sequelae or the death. These were the different levels where we could act. I would like to say that in COVID-19, initially we had to move in the most unfavorable phases of the scheme of Level and Clark. Basically, we had to limit to rehabilitate the patient, to see how many patients died, and trying to do more and more efficient treatments. But we failed in our early diagnosis. We failed initially with our protection systems. And of course, we didn't have any strategy in terms of protection of health. While the pandemic was advancing, we got better in doing the proper treatments. PCR tests were developed for the early diagnosis and for the identification of asymptomatic symptoms. We are speaking now about the asymptomatic phase of the pathogenic period. And what was not done really was promotion of health. But we have to acknowledge that this pandemic has helped us also in many senses. The vaccine arrived, but also one thing happened which could be even positive. It changed our ways of behaving, of being. The streets were full of people walking and running. Spaniards did never run so much. They took out their sneakers from 30 years ago. And all the web pages where they talk about healthy nutrition got many hits. So the approach So in this leveling clock scheme, we went from the red part to the green part, to the most favorable one. In other words, this pandemic is teaching us a lot of things, and very interesting ones. Now, allow me to do a reflection right now. We have seen COVID. We have spoken about COVID to see if prevention is favorable or not. But I would like to explain where the dental profession is taking place, in what environment. Basically, dentistry at present lives or is based on the two last levels of the scheme of leveling clock. Limitation of damagement and rehabilitation, implant-supported restorations, many other restorative procedures, with the aim of rehabilitating. But it also means that this is a failure of the previous steps of the treatments. Does this mean that we don't have an adequate knowledge? Let's see what Spanish dentists do. And this is taken from the Observatorio de la Salud Oral in Spain. These are the last data published from 2019. As you can see, 60% of the activity of Spanish dentists is a treatment activity, it's just a cure. And preventive treatments are just 18%. This is something that we have to take into account and that we should think about. We don't have to blame only the dental profession about the fact that we are just repairing the damage. This is part of also the culture of our society. All the individuals wanted to be passive in the relationship between the doctor and the patient towards the health. The doctor cures and the patient is passive. When we talk about health promotion, we're saying that the patient has to be also one of the main actors and take decisions and be implied and be active regarding the health. And this requires a very important change in attitude, not only in the terms of dentistry, but also in terms of general medicine. But don't be mistaken, the scientific basis of the preventive criteria in dentistry and in medicine are very old. This is a landmark article which would allow us to speak for a whole day about this. Axelsson and Linde, where they showed the results after 30 years of maintenance. And in this study, they showed that with a professional and home care system, it is possible to reduce significantly the periodontal diseases and caries, which, as we all know, are the two main reasons for tooth loss around the world. And if we haven't been able to prevent, this forces us that the present treatments in dentistry are focused on rehabilitation and damage limitation. In other words, we have a lot of scientific evidence to justify the preventive strategies, but I think we are missing an effective involvement, both by the medical profession and the patients who have to be also responsible for their health. I would also mention another issue related to COVID, because it will allow me to link to the next part of my presentation. It was seen that at first, most of the patients were elderly patients, and those were the ones who died. And they had clinical features which were compatible with pneumonia and respiratory insufficiency. But it was also seen that in younger patients, we saw a paradoxical situation with severe sequelae and death, which was not related to what was expected. When, after the vaccine, age disappeared as a confusion factor, we started to understand better the comorbidities. We started to see how many of the young patients present a mobility which is based on these comorbidities. What are these comorbidities? These are basically health features of the patient which lead them to develop a more severe disease. And this has been related to the so-called cytokine storm. Cytokine storm was not described for COVID. It is an organic reaction related with many issues. But here, a very clear relationship was established. This is an article of the New England Journal of Medicine, and this is a review of 2020, where they assess the comorbidities of COVID-19. But I would like also to mention this document of the Spanish Society of Emergency Care Physicians, where you can see the most important comorbidities. And these are basically high blood pressure, diabetes, obesity. These are different conditions which predispose our patient to these problems. These comorbidities, which are associated with the more severe case of COVID, were also mentioned in this review, where they linked the local systemic mechanisms between periodontal disease and inflammatory comorbidities. And they saw very clearly that many of the comorbidities of the periodontal diseases are similar to the comorbidities of COVID-19. In other words, apart from the fact that we have an association or not, it is clear that we are seeing a very, very tight relationship between the pathogenesis of the systemic disease of periodontitis and the physiopathogenesis of complicated cases in younger patients affected by COVID-19. Of course, Dr. Mariano Sanz is going to explain this in an impressive way, because he's the person who worldwide was the first person to speak about this at a very high scientific level, and this had a big impact on the media also, because he explained also the comorbidities of periodontitis and the severity of COVID-19, and this explained why we have to stress the importance of the oral healthcare to prevent the predisposition to COVID. We are basically speaking about systemic inflammation. And if you speak about systemic inflammation, and we see the same comorbidities, I would like to start with a slide which is from the pre-COVID era. We see a relationship between the atherosclerotic diseases and periodontal disease. We see that basically most of the situations are the same in both. Behind this, we have a condition which is called metabolic syndrome. What is a metabolic syndrome? Basically, we have an alteration of the glucose level, hypertension, obesity, and dyslipidemia. It is linked to a cardiovascular risk, metabolic risk of diabetes, and risk of suffering periodontal disease. In other words, this metabolic syndrome, which has a very close relationship to lifestyle, and if we speak about lifestyle, we speak basically about promotion of health. The maximum dimension of promotion of health is achieved by changes in lifestyle. Now, in this metabolic syndrome, as a risk factor in this pathology, we should have to add, and I'm sure Dr. Sanz is going to provide us with relevant information in that sense, we would have to add that it is possible that it also influences in a complicated COVID. We're speaking about a situation which affects a lot of persons, between 21 and 30% of the population. Metabolic syndrome is rising. Probably when the generation of our sons or of our children or grandchildren are getting older, many of them are going to suffer diabetes 2, type 2, or metabolic syndrome, and they're going to facing a situation with a much worse quality of life when they get older. And probably, even if in Spain we are living in a country where the life expectancy is very high, it is possible that in the future, if we don't change many of the circumstances and we don't promote health, we will see a reduction of the life expectancy in future generations. This means that we have to we have to go for a change in paradigms. Dentistry doesn't have to move in the field only of rehabilitation, of limiting damage, or early diagnosis. We have based everything on the inner specific and specific protection and the early diagnosis. That's the prevention we have done in dentistry. That's what we've done when we applied the criteria of Axelson and Linde. And evidence has shown that this is totally efficacious. But this was when we saw the mouth as an isolated area. Now we cannot unlink the mouth from the general health of the patient. And this is when we are starting to speak about health promotion, where we speak about strategies which need a change in attitude and the patients and the population, and which also will force us to go hand in hand with physicians, nurses, and other colleagues. This link, this coordination is going to be stronger and stronger. And for sure, we're going to be much more beneficial for the social goal of the dental profession, which apart from curing dental diseases is helping people to be happier and live longer and have a better life and a healthier life. With this, I want to finish and I want to give the floor to the next speaker. Thank you very much. Could you help me to access the video? Okay. Okay, Dr. Noguerol, thank you very much. It has been a very interesting presentation. It's a very good introduction to everything that we're going to see in this course. You've spoken about what has happened in the last 100 years up to now in very simple terms, but also very serious terms. Because we have to go for a very, very important promotion of oral health and health in general. You've spoken about comorbidities. You've spoken about the metabolic syndrome. You've mentioned many things that I want to speak about, but I have to give numbers, figures. This is a little bit more boring, but it's also necessary. I want to speak about what population are we going to see in the dental offices? What are we seeing at present? It's very important to know on what type of patients we have to act and who we have to care about more. It's very important for our profession. And I'm going to describe it at two levels, at a medical level and periodontal level. Dr. Blas Noguerol has already introduced the essential parts, which are to introduce this global promotion of health. And the basis of our profession is based on the usual treatment of caries and periodontal disease, what is called oral pathologies, oral and dental pathologies, and the prevention. But in a dental office, we can do much more. If we think that a patient is not just a box with gums and teeth, but it's a real living organism, of course, we are speaking about a much wider field. This means that the dental office is not just a place where we perform our daily treatments, which we're doing every day in a very advanced level, but we also introduce other variables. Since we are in SEPA, and we speak about periodontal disease, of course, all of you know that periodontal medicine, in other words, the relationship between periodontitis and other diseases which are outside the mouth, basically diabetes, cardiovascular diseases, and so on, have changed a lot our profession, and they will change it even more in the future. But apart from this, in our dental offices, we can also assess all the comorbidities, or the most important comorbidities Blas Noguerol has mentioned, other comorbidities which are also linked to a systemic risk. This means that we don't have only patients who come to the office to get their periodontitis treated or their caries or their dental aesthetics and so on. We can also assess the persons we are seeing, and especially also what is going to be seen in the future. As Blas had said, metabolic syndrome is going to be rising in the future, and this is going to change our scenario, where the dentists and their hygienists and nurses will act in the future. So we will have to speak about general population, periodontal disease, and chronic diseases, which we can see and which we can contribute to prevent or assess its risk. In general terms, and this is the example of Spain, which is what we, of course, know most or best. In 2020, we had 47,351,000 inhabitants, more women than men, and this is our population at present. In terms of projection, in other words, what's going to happen with our general population in the next years? According to the National Institute of Statistics, they have predicted that between 2018 to 2033, our population is going to increase in 2,300,000 persons. What's the base of this projection? You can see it in this slide, and it's quite important. As you can see, that even if we suspect this and we see it every day, it's very important that we can see here that we have a reduction in natality. We're going to have less children in 2033. Less children are getting born. Between 30 to 49 years, we will have a reduction of almost 3 million of persons, 19.7%. And also look at the pyramid of the population of over 50 years. There, all the groups are going to increase. As you can see also, 25% of the total population in 2033 in Spain are going to be over the age of 64. This means that we will have 3.4 million persons more than at present. And this brings us to our first conclusion. We will see a much older population in our dental offices. This is evident, but here at least we are seeing some numbers which can give us an idea about the problem we're going to face in the future. Regarding what dental patients are going to attend the office, well, the number is going to increase, as you can see here on the slide. This is the difference between 1987 and 2017, 30 years. And as you can see, the number of persons attending the dental office has increased a lot. Still, it's not a desirable number yet. And there is a project for 2030 where SEPA and other societies would like to have 80% of population attending the dental offices. Here you can see the younger persons here attending the dentist, and that with increase of age, they attend less. But taking the previous facts into account, that we are going to have more elderly patients, we will have to achieve that the elderly patients go to the dentist too. Regarding the periodontal disease, which is what we are going to focus on these webinars, we have to ask ourselves what is happening with the periodontal patients. These figures are very well known, and that's good. Worldwide, we have 3.9 billion persons with oral problems. And from them, 35% of the general population has caries in permanent dentition, which is not treated. But also, in the sixth place, severe periodontitis affects 743 million persons. In other words, 11% of population is affected by severe periodontitis. If we extrapolate this to United States, we see that the numbers are quite similar. Adults over 30 years of age, they have almost 65 million persons with periodontitis there, and generally they are mild or moderate periodontitis, and around 9% of the population has severe periodontitis, but the prevalence is huge. In Spain, we also did our own study, which was done with the Complutense University Madrid of the group ETIC, Therapeutic and Prevention of Periodontal Diseases and Periodontal Diseases, where we found a population of 20 million persons, and the numbers are not okay and are not very good. Only 20% of the population is healthy from a periodontal point of view. More than half the population has gingivitis, and more than 1/3 has periodontitis. And this is 2/3 if we're speaking about persons over the age of 55. In other words, with time, the probability of seeing more patients, older patients with more periodontitis is going to increase, even if it's also true that the preventive measures will help us to reduce those numbers. So we have already the second element, which is an aging population and with a high prevalence of periodontal disease. And what are we going to see also in the dental offices? Well, as Dr. Noguerol said, comorbidities. Our patients are not only an isolated mouth. Unfortunately, we have many chronic diseases. We're speaking about non-communicable chronic diseases. And in Spain, we have more than 30% of the population has some type of chronic disease. And here I've put the most frequent ones in terms of percentage of prevalence. The most important is a very high prevalence of high levels of cholesterol, high blood pressure. With the orange arrows, you can see the pathologies, which we are going to try to describe in the following days to see how we can influence in the early diagnosis in the dental office. But as you can see, the percentages are very high. We have many diabetics, 12% of population has diabetes, auricular fibrillation, we're going to see it afterwards. It's also an important issue, but we have one mission, which is like if we were private investigators or from the police, how many of them are not diagnosed? Well, these are just general numbers, but in terms of cholesterol, more than half of the population is not diagnosed. We have to remember that cholesterol is contributing to 60% of the ischemic cardiac diseases and 40% of the strokes. And I mean, in terms of high blood pressure, it's impressive. More than 42% of the adult population has high blood pressure in Spain. These are very high numbers. In males, almost 50% have some type of high blood pressure. And also 1/3 of people with high blood pressure don't know that they have it. So in the dental offices, it's very important that we carry out a screening to tell the person that they have a high blood pressure. So we have two very important things here: cholesterol and high blood pressure. The first factor is diabetes. This was explained in a previous webinar already. As you can see, from the 4.5 million of persons affected by diabetes in Spain, 1.5 million don't know they're diabetic. So they're like a ticking time bomb walking around. And this is also related to the metabolic syndrome. But diabetes by itself also has its own entity and causes a very high number of complications. And it also has a big influence in the cardiovascular mortality. It's the highest risk factor for these diabetic patients. Auricular fibrillation affects 4% of the population. In other words, we have 1 million persons in Spain with auricular fibrillation, of whom 10% are not diagnosed. We have to remember that auricular fibrillation, among other things, favors also the appearance of strokes, 5 times more chances of suffering a stroke. In other words, we have a lot of chronic diseases, we have a lot of pathologies in our patients who arrive to our office, where we can do things. This may sound very simple, but it's very important and it can save lives. In the next webinar, for example, Dr. Nuria Valcorba, Yagoleira, and Sonia Mirabet are going to speak about other very, very frequent diseases like dementia, for example. As you can see here, you can see how dementia has increased since 2011 in Spain, from 117,000 persons to 441,000 reported persons. In other words, almost 4 times more persons diagnosed with dementia, basically Alzheimer's disease. This is also a very important healthcare problem. If we speak about cancer, it's also very important, of course. We have a very high prevalence of cancer, of tumors, and we have to try to prevent as much as we can. It's the best way of treating the tumors. Even if the most frequent cancers are breast cancer and prostate cancers, we also have the highest mortality in the bronchial and lung cancer and colon cancer. And EPOC also, which is also been linked so much to COVID right now, it's also very, very, very frequent. It affects almost 12% of the population, and it increases a lot its prevalence with age. In other words, we are facing a cocktail of chronic patients, some exceptions like we are seeing here on the slide, where the population is affected by chronic diseases in a very high percentage of the patients of over 65 years. Remember, this is the part of population which is going to increase most in our societies, have on average 4 of these chronic diseases. These are called complex chronic patients. So this slide may look kind of pessimistic. An aging population with high prevalence of periodontal disease and an increasing percentage of chronic diseases related to the aging and many other factors. This is very important. Can we do things? Of course we can. As you can see, the persons who died in the number of deaths in Spain. This was a study about the prevalence, global burden of diseases in 204 countries. This was published at the end of 2019. And in Spain, as you can see, most of the patients died due to ischemic cardiopathy, stroke, EPOC, dementia, or lung cancer, as we saw before. And we can influence there because the most important risk factors for these types of diseases and the mortality which is related to that are systolic hypertension, which in 2019 killed more people than smoking. And this is very important to say it. It's almost the same number, but hypertension, high blood pressure, is a very important hidden disease which kills a lot. And in the dental offices, we have a very important mission in that sense, to detect the possible risk of high blood pressure in the patients. High glucose levels in plasma, nutrition habits, high body mass index, and so on. And this justifies that in webinar number 3, we will speak about a protocol which we are developing right now to assess the metabolic and cardiovascular risk in the dental office. We're not going to diagnose anything, but we're going to do a screening so that we can help to have a patient to get a much earlier diagnosis of hypertension and diabetes than if they didn't speak with us. Last, I would like to speak about what Dr. Noguerol also mentioned, life expectancy. It has increased a lot in the last year. So obviously, as you can see in Spain, on average, we're speaking about 83.1 years. It's a very high life expectancy. I think it's the second highest one in the world. But there's another concept which people don't use too often, which is a healthy life expectancy, the number of years a person is expected to live with a good level of health. As you can see in Spain, the average number is 71.3 years. This means that between the healthy life expectancy and the global total life expectancy, we have a difference of 12 years, which are the years that can be lived with a bad general health. And this is very important because the more we do in terms of prevention of health, the more we can change these numbers, because we're speaking about many millions or millions of persons who are affected by chronic disease. And apart from all this, we have a new actor now, which is the infection by coronavirus. The life expectancy, I want to insist on this, is 83.1 years in Spain at 2019. But look what has happened. This is a very important slide. How did the life expectancy change in 2020? In other words, in 1 year, due to the coronavirus pandemics. From all the countries we have in Europe, this is a European statistic, almost all of them, except some of the Nordic countries, the life expectancy has dropped. But as you can see in Spain, it has dropped 1.6 years. That in just 1 year, we have lost 1.6 years of life expectancy. It's a lot, it's impressive. I mean, all the efforts we have invested in prevention and promotion of health haven't had a very strong effect compared to the effect of coronavirus, of the COVID-19 pandemics. And we should think about this. And this is why the third and last speaker today is Dr. Mariano Sanz, who is going to speak about the importance of periodontitis in the pandemics by SARS-CoV-2. I'm going to hand over the microphone to Dr. Mariano Sanz, even if I'm going to stop sharing my screen. And yes, Dr. Sanz, could you share your screen? Perfect, I'm on it, great. Well, Professor Sanz, I think I don't have to introduce Professor Sanz. He's a worldwide reference in the field of periodontics. It makes us really proud, especially Professor Noguerol and me, because we've been students of him and we've learned a lot from him. He's professor of periodontics in the Complutense University Madrid, where he's also co-director of the ETEP study group, Etiology and Therapeutic of Peri-implant Periodontic Disease. He's Doctor honoris causa by 4 international universities, and I want to stop reading his CV because otherwise it's going to be too late. And what we want to do is to listen to Mariano Sanz. Mariano, the floor is yours. Thank you very much, Miguel. And it's a real pleasure to be able to participate in this webinar. I would like to thank SEPA and DENTAID for this opportunity to be here with all of you. I think in the previous lectures, have put into context the importance of the general health and the importance of oral health in general health. Without oral health, we cannot have general health. And I'm going to speak more specifically about the importance of periodontal health in the infection by COVID-19. In these next 20 minutes, I'm going to speak about the following index. I'm going to speak very briefly about the virus SARS-CoV-2 and the COVID-19 disease. I will explain if we have evidence at present which explains why the oral cavity is relevant in the transmission pathogenicity of SARS-CoV-2. I want to speak about the impact of periodontal diseases as a risk of an increased severity in patients who are infected by SARS-CoV-2 virus. And finally, I want to explain the mechanisms we are behind this association between periodontitis and severity of COVID-19. Very briefly about the coronavirus. I think in our country and in the rest of the world, we are all experts in virology and in vaccines right now. So I don't have to insist much more. Just some words. COVID-19 is an RNA virus, a single-stranded RNA virus with a diameter of approximately 100 nanometers. And it's called coronavirus because this group of viruses presents these spikes, these proteins, which are placed in the outer surface of the membrane of the virus, which under an electron microscopy provide them with a crown-like appearance. Also, we have a nucleocapsid where we have these single-stranded RNA of the virus, which is related to the features of this virus. It's very important that this spike, that this crown, so to say, of coronaviruses has a very huge affinity for one receptor, which is present in almost all the cells of the human mucosas and many other cells of our organism, which is this receptor with the angiotensin converting enzyme 2, which is called ACE2. This receptor, which is so important for the infectivity and the transmission of this virus. As you know, this Sas virus, which is the acronym of severe acute respiratory syndrome, has its and is derived from an infection which first affected humans in China in 2002. Afterwards, another virus appeared, which was called MERS-CoV. And it wasn't until 2019 when this new variant of SARS-CoV-2 appeared. In this case, responsible for the infection of COVID-19. As you know, it is not known exactly which is the real source of the appearance of the SARS-CoV-2 virus, but it seems that some animals have participated in the process, transmitting the virus to the humans. In humans, the virus is transmitted basically through aerosols. As you know, we had a lot of information about different modes of transmission, but what we know at present is that basically the aerosols are the basic way of transmission of the virus. And the infectivity depends basically on the ability of this virus, especially the spike protein, to bond to these ACE2 receptors, to penetrate inside the cells and to replicate widely inside the cell. At present, all the variants we know of the virus are small variations of the spike protein and how it connects to the ACE2 receptor to penetrate in a more efficient way inside the cells, where it replicates and creates a very high number of viruses who move out of the cells and infect other cells and other patients. Also, at present, we know quite a lot about the symptomatology. Most of the infected patients suffer a mild disease with characteristic symptoms, but not very specific ones. And only a small group of patients, about 8 to 10% of patients, are going to suffer this cytokine release syndrome, which translates basically these bilateral pneumonias, which can worsen, which can get more complicated with a multi-organ effect. As you can see, around 5% are going to suffer critical disease, but 14% can suffer a severe disease. And as it was said already before, especially in patients with comorbidities. The age factor is very important, and we've seen how with the progression of the vaccination, these numbers, which are basically figures from the first wave, second wave, and starts from the third wave, have changed a lot because the vaccination of the older population has changed this effect on age a lot. But what has not changed is the effect on patients with comorbidities and who are especially susceptible for this. In this context, what can we say about the oral cavity? Well, it is important to know that the oral cavity has some specific features. Professor Herrera and our group published a review where we analyzed in the literature this aspect in a very thorough way. And basically, we tried to answer to these two questions. Is the oral cavity relevant in the transmission and pathogenicity of this infection? And could the traditional oral antiseptics for the prevention of oral diseases could have an effect in this transmission and pathogenicity? What has been seen very clearly is the epithelial cells of the oral mucosa have a very high expression of this ACE2 receptor. And the mouth is the most important way of entrance of this virus. At present, it's very clear that the masks to limit the transmission through the mouth is maybe the most important barrier effect that we can have in prevention of the infection by this virus. The most studies oral antiseptics in terms of possible effect of the virus are cetylpyridinium chloride, povidone iodine, and chlorhexidine. Even if chlorhexidine has a very heterogeneous evidence, but povidone iodine and cetylpyridinium chloride have shown to have an effect in vitro. And as has been seen in clinical study, especially in patients who are positive for COVID-19 but who are asymptomatic, if it's possible to use these elements as a preventive measure so that an symptomatics turns into asymptomatic, or that an asymptomatic infection is not able to affect surrounding persons. And in other words, this could be an important tool to prevent this infectivity. But I would like to insist more in my presentation, especially on this study, which was mentioned by Professor Noguerol before. Here we studied the association between periodontitis and severity of COVID-19 infection. It was a very international study because it was done basically by the group of Doha in Qatar, led by Dr. Khaled Tamimi, who is also professor in McGill, Canada. And we have also worked together with Canadian epidemiologists who have helped us to carry out basically the statistical analysis. Professor Khaled Tamimi and myself, we have known us for many years. I directed his PhD thesis, and Dr. Tamimi did his PhD thesis in the Complutense University, Madrid. Since then, we have had a very fruitful collaboration, and Professor Tamimi asked me to coordinate and help him in the periodontal aspects of the study. And why did we do it in Qatar? For a very simple reason, because in Qatar, they have a very special situation. All the inhabitants of this country have their medical and dental record in just one database. And in this database, all the medical and dental actions are recorded of all the persons of the country. All the hospitals of the country are connected, both private and public hospitals are connected to this database, which means that this is a very important source of information if you want to compare data. This is how we could do this case control study, where during the first and second wave of COVID-19, we recorded all the patients who were COVID-19 positive in Qatar. Of this group of COVID-19 positive patients in Qatar, we separated those who had complications, basically 3 types of complications: admissions in ICUs, need of assisted ventilation, or death. And we compared them with a control group, which was defined as a group of COVID positive patients which were asymptomatics or which were discharged from the hospital without major complications. They didn't have major health problems. So in this scheme, we compared the group of complications in green with the group of no complications in blue. And in both groups, we studied which patients had periodontitis and which did not have periodontitis. In other words, the exposure factor which we studied was the fact of having periodontitis or not. And for that, in order to study periodontitis, of course, we selected patients in the database which had dental radiographs on this centralized database. And also dental radiographs which would allow us to measure the degree of periodontal bone loss. Here you can see the summary of these 1,076 patients. We were able to select almost 570 patients who had radiographic data on where we could do our measurements. We used both bite wings and panoramic radiographs. We measured the interdental bone loss, basically the posterior sextants, because in the panoramic X-rays and the OPGs, these are the areas which can be measured more accurately. We used as a reference the CEJ in the total length of the root to establish percentage of bone loss. Over 30% of bone loss, we defined that the patient was affected by periodontitis using the criteria of the new classification of 2018. We have a very clear support from a scientific point of view of the usefulness of the dental radiographs to measure percentage of bone loss. So that's what we did. And we were able to establish not so much the 4 stages of periodontitis, but we could select those patients which were after stage 3. In other words, with a bone loss which we could ensure on the X-rays, and we compared it to healthy patients or with a very early periodontitis, where the bone loss is difficult to be measured on an OPG. Based on this, we did our measurements on the X-rays. We did our calibration of the examiners who carry out the measurements, and of course, since we had all these data in the database of Qatar, we could compare this and with all the comorbidities which were mentioned by Dr. Noguerol before. In other words, all the health factors which we know for sure that pose a high risk of complications in the affection by COVID-19. At the same time, we could also access the biomarkers, biological markers of these patients through their blood tests. In other words, we could measure factors like the levels of cytokines, of leukocytes, white blood cells, also the alteration of other factors of coagulations like the D dimer, and also the levels of systemic inflammation like C-reactive proteins. With all this data, we established a multivariant model where we established if periodontitis was or not a risk factor of this group affected by complications of COVID. And we could adjust for all the other morbidities that we studied. You can see some examples of patients of the periodontally healthy group or early periodontitis group. It would be this group, and the group of periodontitis with a clear severe problem of periodontitis. Here you can see in orange the patients with periodontitis, in blue the healthy patients. And if we compared it with all the complications, or we separated with death, admission in ICU, or need for assisted ventilation, we can see that there's a clear and very evident association. Up to 10 times more chances of dying if you are affected by periodontitis. Here you have the data of the non-adjusted risk factor, in other words, the raw data, and the adjusted risk factors, the adjusted data, where we have adjusted with regard to all the risk factors. If we compare the data with the biomarkers in blood, we saw again that the group of patients affected by death or admission in the intensive care unit or need of assisted ventilation had clearly a higher level of inflammation, white blood cells, C-reactive proteins, and also pro-coagulation factors, as we know from literature. If you compare this with the correlation with periodontitis and the laboratory data, we also see a very significant association between periodontitis and CRP, and periodontitis and white blood cell counts. How can we explain this very high association which we proved in this epidemiological study? Of course, I'm not going to repeat what Dr. Noguerol explained already. If we are affected by periodontitis, we have millions of bacteria in the subgingival area with a highly inflamed periodontal tissue, where the epithelium is ulcered, and the bacteria of the biofilm, which are in direct contact with that ulcered epithelium, are not only stimulating this systemic inflammation, but also are promoting that those bacteria with have higher levels of pathogenicity can access through these holes between the epithelial cells and can access the inside of the blood vessels and colonize distant areas. We have a lot of evidence about at present of the impact of the oral microbiome on general health and the impact of certain bacteria which can affect different organs, which are placed at a distance remotely, and where they can create pathologies, basically inducing local inflammatory reactions. So this double mechanisms where the systemic inflammation or the passage of the bacteria to the bloodstream can explain in a direct or indirect way the affection of the general systemic health and this effect of comorbidities, which can clearly influence on the course of, in this case, the infection by COVID-19. In the literature, also very specific features were published. For example, the parenchyma of the lung has a very high expression of these ACE2 receptors, and certain periodontal pathogens, if aspirated, these aspirated bacteria is going to induce a higher expression of ACE2 receptors, which means that it's going to promote even more the infection of the lung parenchyma by SARS-CoV-2. Also, there's very specific bacteria like Fusobacterium nucleatum, which is a bacteria which is present in our subgingival biofilm. It has also been shown that this bacteria is able to overexpress this receptor, ACE2. And it's also able to induce the production of interleukins in these alveolar epithelial cells. In this way, it can also reinforce this cytokine storm. I apologize if I've been speaking a little bit fast, but I think that we know all the mechanisms of COVID-19 right now. I just wanted to mention the importance of periodontal health in this infection as an example of the importance of periodontal health in the general health. And during this number of webinars sponsored by SEPA and DENTAID, we will explain this very important aspect of the periodontal health for the prevention of many of the chronic diseases which affect the human being. With this, I would like to say thank you to all of you. And of course, I'm here to answer any question you might have. Thank you for everything. Thank you very much, Professor Sanz. I mean, if somebody didn't understand these things, now they cannot say, they do not understand them. It was a very good explanation. And also, I think you clarified many things for us. Well, with this, we have come to the end of this first session, where we have established a basis, which I think is very important. And Dr. Mariano Sanz has said it very well. We have to define the importance of the oral health inside the general health, in the promotion of general health, as Dr. Noguerol has said. The importance of especially periodontal disease in the evolution and risk of suffering very relevant chronic diseases due to both the prevalence or the mortality and morbidities. And this can also be referred to, as Dr. Sanz said in the third lecture, to this medical problem which is attacking us so much in the last days, the COVID-19 pandemics. I just have to say thank you to all of you for attending this webinar. Thank you to the speakers, of course. Thank you to the organizers, SEPA and DENTAID. I would like to say that next Thursday, we will have our second webinar at the same time, where we're going to speak about the relationship between periodontitis, periodontal diseases, and systemic diseases, which are very, very relevant. So thank you. Thank you to all of you. Take care. And see you again next week. Thank you. Thank you, Miguel. Thank you very much.